Hi everyone, thanks for joining me today on this episode of Blister Prevention Office Hours. We are going to be looking very closely at posterior heel blisters today. And this is where my special interest started with blisters. We're going to look at the common understanding of posterior heel blisters. We're going to look at the relative motion or rubbing scenarios at the back of the heel at both heel lift and heel strike. We'll look at the research very briefly. I'll talk about my experience with these blisters. We're going to look very closely at how preventions work and finish off with a recap and questions. So the common and, might I say, incorrect understanding of the cause of posterior heel blisters is that your shoe rubs your heel or your heel rubs the shoe. Well, if we have a closer look at what's going on at the posterior heel, if we just add in some labels, we've got the posterior calcaneus, we've got the skin surface and the subcutaneous soft tissue. Obviously, those soft tissue layers run parallel with the skin surface. This is just schematic. And if we add in the shoe and the sock, it quickly becomes apparent that it's actually impossible for your shoe to rub your heel or for your heel to rub your shoe because the sock's in the way. So what's rubbing what? Is rubbing even important to blister formation? Because we know that blisters are caused by repetitive shear deformation. Well, let's have a quick recap about what shear deformation is. Shear is basically the give in the soft tissues. So as the bone moves back and forth, the skin doesn't necessarily follow straight away, if at all, and the soft tissue layers are having to cope with that differential. So they stretch and distort or deform as a result of that bone movement relative to skin movement. So it's important to remember that obviously the foot isn't a block of cement. The bones move within the foot and the skin doesn't necessarily follow. And that's kind of why skin markers aren't always indicative of bone position. Unfortunately, shear isn't readily visible because it's basically under the skin surface. It's happening inside the foot. So that makes it a little bit difficult to fully appreciate. And as you can see here, you don't need rubbing for shear. You can see that the skin surface isn't moving at all. And yet as the bone moves back and forth, the soft tissue between skin and bone is stretching and distorting or deforming. And that's what shear is. So let's have a look at some rubbing scenarios or some relative motion scenarios, same thing. I use those two terms synonymously. At the posterior heel, at heel lift and heel strike. So first of all, heel lift. Now, I apologise for the complexity of this slide, but essentially we're going to compare these three scenarios to the neutral or relaxed state. So let's have a look at each one. So as the foot moves through mid-stance and it comes towards heel lift, the Achilles pulls on the calcaneus, pulling it upwards. And if friction levels determine that the skin and the sock and the shoe remain in stationary contact, given that the heel has to move up a certain amount, then it's the job of the soft tissues between skin and bone to allow that to happen. So they deform or they stretch and distort to allow that to happen. Now, if we can compare that to what happens if we have slippage of the skin on the sock and see what that means for the magnitude of shear deformation, you can see the magnitude of shear deformation has reduced because the skin has moved relative to the sock. So as the bone has moved upwards, the skin has been able to move at an earlier moment in time with the bone movement, and therefore that reduces the magnitude of shear deformation. Similarly, if we get that slippage between the sock and the shoe, again, shear deformation is less because the skin has been able to move in sync with the bone at an earlier moment in time, thereby reducing the magnitude of that shear deformation. So if we have a look at them all on that single slide again, in all three cases, we have soft tissue shear deformation. So blisters can occur in all three scenarios. Rubbing on the skin only happens in one of these scenarios. So Abrasion to the skin surface can only happen in one of these situations, and it won't happen if it's a very low friction rub, but if it's a high friction rub, you will have the potential for abrasive injury to the skin. An abrasive injury or an abrasion is essentially a superficial to deep wear injury. Yet, all three scenarios can cause skin damage, and that's because we're talking about the skin damage that occurs with repetitive shear deformation, which isn't a superficial to deep wear injury. It's a mechanical fatigue within the layers of the epidermis. Interestingly, shear deformation will be highest where there's no relative motion between the skin, sock, and shoe. Given that the bone has to move up a certain amount, the soft tissues will have to shear or deform to allow that to happen. And the more rubbing that occurs at a material interface, the less shear deformation that has to happen within the soft tissues of the skin. So basically, that isn't a blister prevention strategy, and these are. So let's look at heel strike now. It's exactly the same, but in the opposite direction. As the calcaneus moves down at heel strike, if friction levels determine that the skin remains in stationary contact with the sock, which remains in stationary contact with the shoe, then given that the bone has to move down a certain amount, the soft tissues will stretch and distort or deform to allow for that to happen. And if we can compare that to the magnitude of shear when there is slippage between the skin and the sock, then the skin is released to move in sync with the bone at an earlier moment, and therefore it reduces the magnitude of shear deformation. And it's the same if we get that slippage between the sock and the shoe. So all of those things on the one slide, again, in all three cases, we have shear deformation, so blisters can occur in all three scenarios. Rubbing only happens in one of these scenarios. So if that is a high friction rub, we risk abrasion damage to the skin, which is a superficial to deep wear injury. Yet all scenarios can cause skin damage. And that's because we're talking about the skin damage of repetitive shear deformation, which isn't a superficial to deep wear injury. It is an intraepidermal mechanical fatigue of the connections between skin cells within the lower part of the stratum spinosum of the epidermis. Again, shear is highest where there is no relative motion between the skin, sock, and shoe. And when there is relative motion between either the skin and sock or the sock and the shoe, then shear deformation is reduced. If I put a couple of labels in here of actual preventions that fit the bill here, on the far right, we've got Engo patches. That's a low friction material. It's like a self-adhesive sticker that you stick to the shoe, the back of the shoe, and the sock is able to move up and down very easily over it, thereby releasing the skin to move in sync with the bone at an earlier moment in time, thereby reducing the magnitude of shear deformation. Same thing with lubricant, but this time between the skin and the sock. So the skin is able to move relative to the sock very easily. And if we try and increase friction levels at any of these material interfaces at the posterior heel, like a heel grip or neoprene, then we're encouraging things to stay in stationary contact, and there will be a higher magnitude of shear deformation in the subcutaneous tissues between skin and bone. So rubbing or relative motion is not the problem. Shear is the problem of blisters, and rubbing is often the solution, as long as it's a low friction rub. So if it's a low friction rub, it's a blister prevention strategy. If it is a high friction rub between the skin and the sock, then we risk abrasive injury as well. Okay, so now we're going to have a quick look at some research. This research was conducted by Farida Hashmi and colleagues in the UK in 2013, where they produced blisters on the posterior heel of 30 subjects using this load applicator mechanism. And basically this jig moved the applicator up and down, and the surface of the applicator was rubber, so it was a high friction material, and that created the shear deformation in the skin at the back of the heel. And the point I want to make here is that they discuss two things in this paper, and these weren't the findings of the paper, but they were just two things that were mentioned in the discussion of the topic. And one was that the heel moves down relative to the back of the shoe at heel strike by a whopping 1.5 centimeters. Now, that is a lot. That is more than I would have ever thought. And I think most podiatrists would think that that is a lot. And I hazard to say that as podiatrists, we aim to make that as little as possible. We want it to be zero. Now, 1.5 centimeters is maybe not to be taken as gospel. This 1.5 centimeters was discovered as part of an unpublished pilot study, and there's really no information on how it was conducted. So I don't know the number of subjects. I don't know the type of shoe, whether it was a slip-on shoe, whether it was a lace-up. I don't know how it was measured, whether they cut a hole in the back of the shoe, whether they used a skin marker or like a bony landmark. I'm not really sure, like the malleoli, for example. Seems like a pretty easy thing to do if there's a final year student looking for a project to do, as long as you've got some good, like a good video analysis equipment. It would be great to be able to verify that 1.5 centimeters is a normal amount for the heel to move relative to the back of the shoe. The other thing that they mentioned was the majority of shear at the heel occurs as the foot moves down into the shoe after heel strike, and so it is unidirectional. Now, this was just stated. There was no reference, and I mean, I didn't know it. I didn't know that was the case. I know that it definitely hurts more at heel strike than at heel lift when you've got a blister. So there's no doubt that there is a lot of shear at heel strike, but how relevant is the heel lift shear event? Is it negligible? The reason this becomes important is if blisters are caused by a repetitive shear deformation, the repetitive part is very important. So the more repetitions, the sooner blisters will occur. And if it is actually unidirectional, then that means that there's one shear episode per step. If it's bidirectional, there's actually two shear episodes in one step, so it's double. Maybe that is part of the reason why posterior heel blisters are very common. I don't know. But something to be also maybe thought about a little bit more and even measured if we can. Anyway, so the heel moves down 1.5 centimeters relative to the shoe at heel strike, and presumably it moves up 1.5 centimeters relative to the shoe at heel lift. And when we say heel, I'm assuming that we're talking about the skin, not the bone. So the bone's actually moving up and down more than the skin. Yeah. Instinctively, this seems like a bad thing. I think as podiatrists, we're more comfortable with thinking that there's no relative motion there. So is it actually a bad thing? Because we've just said that rubbing or relative motion is not the problem. Well, the thing is, you've got to not so much focus on rubbing, but you've got to focus on what that rubbing means for shear deformation, for the magnitude of shear deformation. Because if we were laser-like focused on preventing rubbing, then we would have this situation where we're actually encouraging shear deformation to be larger. So the moral of the story here is that keeping the skin, sock, and shoe stuck together is not the primary aim in preventing posterior heel blisters. We've got to focus on the magnitude of shear deformation. Okay, just quickly, my experience with posterior heel blisters. So these were my most common blister. I'd get them with walking, not hockey. Hockey would give me an edge blister at my first MPJ. I wasn't aware that my heel was slipping up and down excessively, and in fact, I optimized shoe fit and lacing to ensure that that wasn't the case, because my understanding was I did not want my heel lifting up too much because that's rubbing. Things that didn't help were calf stretches. Again, I didn't want my heel lifting up so much, so I did calf stretches, but I don't know, perhaps I wasn't tight in the calf muscles. I didn't think I was, but I was just trying to throw everything at it. I couldn't find a sock combination that would help. Things that did help but didn't help enough. One was taping, definitely helped. I'd rather have it than not have it, but I would still get blisters under the tape. Firm lacing did help, but not enough to keep me blister free. And minimizing heel strike was one thing that I would do once I had a blister, because a heel strike was when it was at its most painful. So I would try and affect like a forefoot strike or a flat foot strike, which is kind of hard to do when you're walking for exercise because you can't really get much pace up. And the thing that helped the most was Engo patches. Now, I had two dilemmas here, two conceptual challenges that I had to get my head around. First was, if blisters are caused by rubbing, I'm eliminating the rubbing by putting tape on my skin. Nothing could rub my skin if I had tape on it, and yet I'd still get a blister. And not only that, the thing that helped the most made rubbing easier. So that was my confusion and started my whole understanding of blisters. This is my current walking shoes with the Engo heel patch attached. It's a polytetrafluoroethylene material, so it's very low friction, so my sock can glide up and down on the Engo patch very easily, and that reduces the magnitude of shear deformation at both heel lift and heel strike. So friction reduction strategies aim to allow the skin to move in sync with the bone at an earlier moment of time with every step. That's how they reduce the magnitude of shear deformation. Just read that again. Okay, now we are really going to get into the nitty gritty. So strap yourselves in. We're going to look at all the blister preventions that can be applied to the posterior heel, or as many as I could think of, and exactly how they work. Apologies for this complicated slide, but essentially if I transpose all that or superimpose all that onto this magnitude, this mechanisms chart, we're going to look at coefficient of friction reduction strategies, lubricants, Engo patches, double socks, moisture wicking socks. We're going to look at pressure reduction strategies like donut pads, cushioning, foot strike angle. Both of these go together to reduce friction force. We'll look at materials that absorb shear like Pelitech pads, gel materials, and padded socks. We'll look at the adhesive materials that we can apply to the foot that spread shear load, and of course reducing bone movement. Okay, so we've seen these pictures before, and what I've done is I've added a dotted line in here just to give references to what's moving and what's not moving. All right, lubricants and moisture wicking socks are a coefficient of friction reduction strategy that work at the skin sock interface. Now, it's easy to understand lubricants. You put like a Vaseline, for example, on your skin. It makes it slippery, and so your skin is able to move relative to the sock. Moisture wicking socks, the way they work is they are trying to negate the high friction effect of moisture on the skin surface. So they're trying to get that perspiration that comes from the skin and get it to absorb into the sock and through the sock, so it gets to the shoe and it either absorbs into the shoe materials like the lining or the insole, or is evacuated into the airspace of the shoe and ideally evaporates through the upper of the shoe. That's how moisture wicking socks work. Now, I think that you can appreciate whether you've used lubricants on your foot or not. Most people have used a moisture wicking sock. Lubricants make it slippery. They obviously make it slippery. I don't feel that my foot's that slippery when I wear a moisture wicking sock, even when I've been exercising for a while. So with each sort of mechanism, different strategies can work better than others, if you know what I mean. Engo patches, we've looked at this one, but I've drawn it in with the yellow line here. So the yellow Engo patch is it's adhered to the shoe, which is the blue surface. So there's no movement there. And what happens is, because of the low friction surface of the patch, the sock is able to move up and down very easily. That releases the skin to move in sync with the bone at an early moment of time, thereby reducing the magnitude of shear deformation. Double socks. The idea here is that the lowest frictional interface is the sock-sock interface. So the normal sock is the pink one here. The second sock is the yellow one. So the second sock stays in stationary contact with the skin. The normal sock stays in stationary contact with the shoe. And there is slippage between the two sock layers. So that releases the skin to move in sync with the bone at an earlier moment in time, thereby reducing the magnitude of that shear deformation with every step. Pressure reduction strategies work by basically, the harder things are pressed together, the higher the friction force. So if things aren't pressed together as hard, the lower the friction force. So the earlier we can get slippage at a material interface, so that skin can move in sync with the bone. It will happen at both interfaces, both the skin sock and the sock shoe interface. So all these cushioning materials, and I just want to elaborate on foot strike angle. So Doug, Richie and I were on the P3 podcast with Talisha, I don't know, six months ago, maybe more. And we were talking about my posterior heel blisters, and Doug suggested that stride length could have been an issue. And this kind of elaborates on why. As stride length increases, the foot strike angle will increase. Now, 35 degrees is probably a bit crazy, but it just really demonstrates it more clearly. The higher the foot strike angle gets, the more posterior the ground reaction force is applied, and it moves posteriorly more towards the posterior heel. So if you've got someone that is overstriding and struggling with posterior heel blisters, this is why shortening their stride length is probably a good idea, particularly given that heel strike is possibly the biggest factor, more than heel lift. Make sense? And thanks to healthystep.co.uk for letting me muck around with their image to show you that. Okay, shear absorption. Now, this is a bit different. We're not talking about frictional interfaces so much. We're talking about the give in the material, or the shear deformation that happens within the external material, not the skin. So here we've got a padded sock. So I've got a double thickness pink line here. The skin side of the sock remains stationary with the skin. The shoe side of the sock remains stationary with the shoe. And as the heel bone moves up, the skin is able to move up with it at an earlier moment, because the sock itself undergoes shear deformation. And then the same in the downwards direction. If we look at a gel material, so that's the yellow, this is the gel applied to the skin. So the skin and the gel remain in stationary contact. The gel and the sock remain in stationary contact. There's nothing moving relative to one another here, except because of the deformation that occurs within the gel, the skin is able to move in sync with the bone at an earlier moment in time, thereby reducing the magnitude of that shear deformation with every step. This is gel applied to the shoe or a Pelitech pad. So again, these materials undergo shear themselves. So the pad is stuck to the lining of the shoe. The material is stuck to the sock as well. So there's no relative movement anywhere, except there's give within the Pelitech pad or the gel material. Shear load spreading is a bit harder to explain with those pictures I've been using, but the easiest way I can describe it is to compare it to how cushioning works with the perpendicular load. So if this is a metatarsal head and there's no cushioning, the perpendicular load is spread over a certain area and peak pressure is a certain amount. Now, if we implement some cushioning in the form of, say, an insole, then the area that vertical load is applied is larger. So we're spreading the same normal force over a larger surface area, thereby reducing peak pressure. So similarly, it's possible that if we've got peak shear at this at-risk location, perhaps a bony prominence, if we apply tape to this whole area, instead of the skin pulling back and forth or the bone moving back and forth and pulling the skin and that shear deformation being very pinpoint, we're applying shear to a much larger surface area. And so we're not getting rid of shear. It's still happening in that skin, but we are potentially reducing peak shear at this particular location. Obviously, if the heel bone doesn't have to move up or down as far, then shear deformation magnitudes will be lower. And this is why potentially calf stretches and things like heel lifts and heel height differential on the shoe may be relevant. I can't say that I've noticed a correlation between people that have big trouble with posterior heel blisters and people that are tight in the calf muscle, but you can see the theory here. And to finish off with, there are another couple of factors that we should consider. Obviously, Haglund's deformity, because there's more pressure. Perhaps frontal plane motion of the calcaneus is relevant. I don't know. I can't say I've noticed a correlation. And also the question of whether it's a biphasic shear. So is the shear event that occurs at the posterior heel unidirectional in that it only is significant at heel strike, or is it bidirectional? Have we got a biphasic shear event at the posterior heel? And does that explain why posterior heel blisters are relatively common? Oh, I had this slide just to reiterate that it's the repetition that is important in repetitive shear deformation that causes blisters. So if we are having shear twice per step as opposed to once per step, then blisters are more likely to happen earlier. And in terms of this biphasic shear event, Yavuz and colleagues in 2008 showed the biphasic shear episode that happened to the plantar surface of the foot, and the plantar forefoot experiences this bidirectional shear, so both anterior and posterior, whereas the plantar heel only experiences the anterior shear. So that may possibly go some way to explaining why plantar forefoot blisters and ulcers are more common than plantar heel blisters and ulcers. I don't know, maybe. Okay, let's wrap things up with a recap. I just wanted to have a few sort of nuggets for you to chew on the way home tonight. Blisters are caused by shear. They're caused by repetitive shear deformation, not rubbing. Rubbing is not required for shear or blister formation. Low friction rubbing reduces shear magnitudes because it frees the skin surface so it can move in sync with the bone at an earlier moment with every step. High friction rubbing sees higher shear magnitude plus the risk of abrasion. Now, if that high friction rub is happening between the skin and the sock, then that abrasion can occur on the skin. If that high friction rub is happening between the sock and the shoe, then that abrasion can occur to the shoe lining at the heel counter. And I'm sure you've seen people that wear holes in the back of their shoes, so this is probably why. And of course, the sock can cop it in either situation. Shear is normal, it's important to point out, and really the skin and the foot in general is able to put up with a lot of it. And shear isn't easily visible, so it's kind of hard to appreciate because it's happening under the skin surface within the foot. Rubbing isn't friction. Friction is the force that resists relative motion, and rubbing is the relative motion. So the friction force resists the rubbing. So when we talk about blisters, we really shouldn't be using the word friction to mean rubbing. And rubbing can happen at any material interface, be it the skin-sock interface, the sock-shoe interface, the sock-sock interface. If we think about blisters more broadly, it could be the skin-skin interface of the interdigital space, and it can even be the shoe-ground interface. Coefficient of friction reduction preventions promote earlier slip via reduced friction force. And so do pressure reduction preventions, because friction force equals coefficient of friction times normal force. So if you reduce the coefficient of friction, which is this, you'll reduce the friction force. If you reduce the normal force, which is pressure, you'll reduce friction force. And the lower the friction force, the easier it is for there to be relative motion at one of the interfaces. Allowing rubbing doesn't mean the heel has to come out of the shoe. So, you can rely on the shoe upper, generally just good shoe fit, and of course lacing. And it's also possibly, well, it is important to realize that there probably is some relative motion of the heel relative to the shoe that is normal. Is that 1.5 centimeters? I don't know. I think that needs to be verified. But there you go. And the way we can reduce shear magnitude is we can absorb it with cushioning materials, gels, Pelitech pads. We can spread it with adhesive products like moleskin and taping. We can reduce bone movement, and we can reduce friction force by either reducing the coefficient of friction or reducing pressure. And essentially, we've been mainly looking at all of these ways of reducing the magnitude of shear distortion. And we've had a quick look at the importance of repetition. Okay, so that's it. I've got some questions. If you have a question, just type it into the chat box, or feel free to turn your mic on and ask away. So Tala asks, is the management of blisters the same in diabetics as it is in non-diabetic patients? Well, there's definite similarities, and that is the mechanism. Friction blisters are caused by repetitive shear deformation, whether you're diabetic or not. If we talk about ulcers, of course, ulcers can be caused by other things like skin tears or scratches in the garden, or burns, of course, that can cause a blister, but that's not a friction blister. So, and that can result in an ulcer. But there are definite differences, of course. So with diabetics, if they have had high sugar levels for a long time, they could be neuropathic and have arterial insufficiency components. The pain perception is an issue, so you can't really expect a neuropathic diabetic to be able to nuance and fine-tune and troubleshoot blister areas and remain blister-free, because they just don't get the hotspot sensation. So it's very difficult for them. So for that reason, you probably just want to start at the top rather than try the things that work a little bit. Perspiration isn't an issue in diabetics that have autonomic neuropathy. So that's generally more of a non-diabetic aspect to blister formation. Soft tissue stiffness, the soft tissues and connective tissues in diabetics is stiffer. So basically an injurious amount of shear deformation will be lower in magnitude if your soft tissues are stiffer. So I hope that makes sense. So basically, if you're a diabetic and you have very stiff connective tissues and skin, then shear deformation will peak sooner and become injurious sooner. So it takes a lower magnitude of shear deformation before it becomes injurious. So yeah, they're the main differences in terms of diabetic patients. Carmel and Gillian asked variations on a theme. What are the best treatments and how to manage? Well, in terms of first aid, I encourage people to judge what they've got to do based on the integrity of the blister roof. So if the blister roof is intact, we need to give a bit of protection to that skin which has lost its structural support from underneath because of the tear, the mechanical fatigue. So just an island dressing like a Band-Aid is really all we need in terms of first aid. If the roof is torn, we need antiseptic to prevent infection, plus the island dressing, and that will also absorb fluids from the blister. And if it's de-roofed, we need the antiseptic to prevent infection, plus either an island dressing or a hydrocolloid would be a better option. Why a hydrocolloid for this one? Because a hydrocolloid needs a raw blister base or a raw wound base to be able to create the optimal conditions for healing. But of course, that is just first aid. And if you want to implement the kind of treatment that is meaningful in terms of allowing someone to put their shoe back on and keep walking or running in spite of that blister, then you have to implement something that is going to reduce the shear magnitude in the soft tissues, because without it, the blister will get worse. A Band-Aid is not going to, or a Compete or a hydrocolloid is just not going to cut it. So you have to have the blister prevention in place during blister treatment for it to be effective, so that it's not painful, and so we get some sort of momentum in terms of blister healing in spite of the ongoing activity. And finally, Nadine asks, strategies to prevent blisters for clients with fragile skin. Well, I had to think about this one, and I'm not sure about why the skin's fragile. Is this an elderly patient and they have fragile skin? Do they have dermatitis or eczema or something? Is there a skin graft involved, or like a scarring or something like that? But basically, if the skin's fragile, then I just want to go top shelf. So if we're talking about posterior heel blisters, for me, that's Engo patches, and that should be all we need to do. I probably wouldn't want to put anything adhesive on fragile skin, so that takes tape, moleskin, and felt donut pads out of the equation. I probably don't want to put anything on the skin either, so in case the lubricant annoys the fragile skin. And I also wouldn't want to encourage rubbing between the skin and the sock, because the thing we know with lubricants is that the lubricant disperses into the sock, and as it does so, the effect is reduced. And our best guess to how long it takes is an hour and a half. So it takes that long for friction levels to actually increase above baseline, and therefore that rubbing becomes abrasive. And obviously we don't want that on fragile skin. So yeah, for mine, for posterior heel blisters, I'd go Engo patches. If you didn't want to use Engo patches for some reason, I'd probably try Pelitech pads. They can be a good option at this blister location. Gel is great as well, like Silipos gel sheeting. However, I'm a bit cautious about using gels when there is skin that's already blistered or that is weepy for any reason, because the gel material, it doesn't absorb anything and it just kind of accelerates maceration. So while I love using gel materials for lots of toe blisters as a prevention, I don't like using gels on the toes while we're doing treatment because of that reason. So yeah. So that's that. Let me just quickly check. So we've got no questions in the chat box. So guys, I'll bid you farewell for today. We're going to talk next month about that research from Hashmi and colleagues in greater detail. And yeah, if you've got any questions, what I suggest that you do is hop over to our pro sites. This is for podiatrists and healthcare professionals, so it's pro.blisterprevention.com. Head to the Learn tab, click the little arrow, and you'll have an option for office hours. This is where we have our replays. And if you have a question, you can pop it in the comments section there, and I'll get an alert and I'll be straight on there to answer your question. So thanks for joining me again, and we'll see you on the first Wednesday of March for our next episode of Office Hours.